Hello friends, now we'll be seeing a topic on spinal tumors, and before starting I would like to thank Chandana Shri ma'am for sharing these wonderful notes with us which are very helpful for quick revision. The link for the notes is given in the description below. You can download it from there. So without any delay, let's get started. So spinal tumors, these are 20% of the CNS tumors and these occur in the spine. Majority of these are benign in nature. So to classify them, they could be extradural or intradural. Most of them are extradural. That are bony vertebral tumors, could be from the vertebral body or the posterior element. The most common being metastasis. Others like multiple myeloma, lymphoma, chordoma, hemangioma, Jan cell tumor, osteosarcoma are some others. Then we have peripheral nerve sheath tumors. What are the clinical features of these tumors? So in these there will be focal back pain which is gradually worsening and unresponsive to rest, increased during the night in the recumbent position and worsened by valsalva, percussion or tenderness. There will be bone pain, bone destruction and pathological fractures, neuropathic pain due to root or meningeal irritation. In peripheral nerve sheath tumors, there will be extramedullary root or cord compression causing radiculopathy followed by myelopathy. Then we will see about the intramedullary tumors, of which they are divided into extramedullary and intramedullary. Intradural tumors are divided into extramedullary and intramedullary. So more common is the extramedullary, which is around 40%, and intramedullary is around 5 to 10%. So what are these extramedullary tumors? These are meningioma, paraganglioma, schwannoma, neurofibroma, and the dermoid. So clinical features of these extramedullary tumor is extramedullary cord or root compression causing myelopathy, especially in the meningioma, and can also cause Brown-Sequard syndrome followed by complete loss. Compression first affects the long trach lying in the periphery of the cord, and later there will be radiculopathy associated with pain and paresthesia. These are the features for the extramedullary. Now coming to the intramedullary, which is the least common. These are ependymoma, subependymoma, astrocytoma, glioblastoma, hemangioma, and metastasis. Among these, 90% are benign. So what are the clinical features? Progressive myelopathy, which mimics syringomyelia, that is central cord syndrome. Then unilateral Brown-Sequard syndrome, which progresses to bilaterally when tumor enlarges. Neurological deficit is mainly below the level of the lesion. Sensory loss and sacral sparing can be seen. Sphincter dysfunction can be seen. And hydrocephalus can be seen in the malignant tumors. For evaluation, we go initially for plain X-rays, which are insensitive and non-specific, but generally are done initially. In extradural, we'll see osteoblastic or osteolytic lesion in the vertebral bodies. We can see pedicular erosion, enlarged intervertebral foramen, and vertebral collapse. In the extramedullary, we can see the enlarged spinal canal with calcification. In the intramedullary, we can see the spinal canal widening, posterior scalloping of the vertebral bodies. MRI spine, which is more superior to CT, for the spinal tumors. CT is primarily for bone tumors. Then we have myelography, which helps in distinguishing between the extra and the intradural tumors. Bone scan when we are suspecting vertebral body lesions. Spinal angiography when we are considering hemangioma to plan angioembolization of the vascular lesion. Lumbar puncture if we are considering leptomeningeal spread of tumor. Now coming to the treatment. So treatment is firstly the spinal cord compression has to be managed. So first of all, we'll go for steroids. That could be dexamethasone at around 4 to 24 mg 6 hourly. Then methylprednisolone can also be used. Emergency radiotherapy in the form of 30 gray in 10 fractions. Surgical decompression, which are indicated especially in the case of cord compression, which are not resolving despite steroids and radiotherapy. Bone compression contributing to nerve deficit, neurological deficit. Then total surgical excision, which is the treatment of choice for most benign tumors and some malignant tumors. Here we go by the laminectomy approach, excise involving the dura and the nerve roots, which are infiltrated. And after the surgery, we go for stabilization by edge fixation or laminoplasty. And meningeal meds and CT leptomeningeal meds are managed by chemo and radio. Vertebral meds are managed by palliation, bisphosphonates, and complication treatment, treatment of the metabolic complications. So this was all about vertebral tumors.